Welcome to Behind the Sports Medicine Podcast, proudly sponsored by AJR Sports Science and Healthcare Consulting. At AJR, we are committed to offering a comprehensive range of exceptional services, including applied sports science analytics, healthcare and sports medicine consulting, and leadership and coaching development. To learn more about AJR, visit their website at ajrsportscience.com. I'm your host, Andrew Rizza, an allied healthcare professional with over 25 years of experience. My career has primarily spanned private physical therapy and public school athletics. Driven by curiosity and a passion for the industry, I created the Behind the Sports Medicine podcast to explore the ever-evolving landscape of healthcare with a focus on sports medicine, physical therapy, athletic training, and sports science. Each week, we'll dive into the challenges healthcare professionals encounter and discuss how collaboration can enhance understanding within the industry. Our goal is to improve the experience for patient and athletes alike. Now, on to the show. On this week's Behind the Sports Medicine podcast, I'd like to welcome Dr. Michael Beasley. Dr. Beasley is a pediatric sports medicine specialist with a focus on sports injury prevention and overuse injuries at Children's Hospital of Philadelphia. He provides comprehensive clinical care for pediatric, adolescent, and young adult athletes with a special interest in treating patients with concussion, spondylolysis, and throwing injuries. Dr. Beasley's biggest goal is to get young athletes back to their sport as quickly but as safely as possible. He likes to discuss all pain and injuries with a particular focus on the sports and even positions involved, making sure that patient and family has a plan that fits specifically with their activity goals. Dr. Beasley received his Bachelor of Science in Biotechnology at the University of Nebraska of Omaha. His medical degree was received at the University of Iowa's Carver College of Medicine. He completed his residency at the Phoenix Children's Hospital Maricopa Medical Center in Phoenix, Arizona. He completed his fellowship in primary care sports medicine from Boston Children's Hospital and Harvard Medical School, as well as Rabkin Fellowship in Medical Education from Beth Israel Deaconess Medical Center in Boston, Massachusetts. In addition to his clinical work, Dr. Beasley has a passion for medical education. He has served on numerous local and regional committees as well as professional societies, such as the American Academy of Pediatrics Council on Sports Medicine and Fitness, the American Medical Society of Sports Medicine, and Pediatric Research in Sports Medicine. He has taught residents, clinical fellows, and research fellows on a variety of orthopedic and sports medicine topics, such as the shoulder, knee, and spinal injuries, as well as concussion, performance-enhancing substances, and return to sports after illness. He has also developed novel teaching modules for joint exams between pediatric trainees and faculty, and continues to focus on developing new, innovative teaching methods for sports medicine. Dr. Beasley hopes that through teaching other doctors as well as patients and their families about sports medicine, young athletes at all levels will know they have a plan in place not only to get them back, but hopefully keep them back to any activities they enjoy. Now, on to the show. Hey, everybody. Welcome to Behind the Sports Medicine Podcast. This week, I have Dr. Michael Beasley, primary care sports medicine physician for Children's Hospital of Philadelphia, formerly primary care sports medicine physician from Children's Hospital Boston, where I had met Dr. Beasley years ago, and we were sad to see him leave. But he's building a new practice now, and they're going to love him in Philadelphia. Dr. Beasley served as a former team physician for Northeastern University, my alma mater, and UMass Boston. He also served on a multitude of leadership teams and committee services over his career in Boston, and was the independent neurotrauma expert for New England Patriots for a short time. And we also had the chance to serve on two boards in Massachusetts, concussion boards, which was great to be able to do that. So Dr. Beasley, welcome to the podcast, and thanks for coming on today.
Yeah, thanks for having me. Always good to catch up.
I think the one thing we wanted to kind of chat about today is your experience as a primary care sports medicine doc, and describe where you got to today, how you got there, and what people can expect when they hear primary care sports medicine versus orthopedic surgeon.
Yeah, it's a huge field. It's relatively new compared to other aspects of medicine. I think when I applied for my sports medicine fellowship, there were probably less than 10 or around 10 pediatric sports medicine programs in the nation, Boston Children's being one of the oldest and the largest for sure. And now it's blown up. But you can get to sports medicine, primary care sports medicine, medical sports medicine, whatever you call it. But you can get there from a lot of different training. You can be family medicine, which is probably where it's really started from, and then internal medicine, emergency medicine, physical medicine and rehabilitation, PM&R. So you can get there a lot of ways. For me, I always knew I wanted to do pediatrics. And then I did my pediatric training in Phoenix at Phoenix Children's Hospital, and then went to Boston for my sports medicine fellowship, and then practiced there until just moving closer to my wife's family in Philadelphia. And so, boy, it's a pleasure to move from one fantastic hospital at Boston Children's to another fantastic children's hospital at Children's Hospital of Philadelphia. I've been blessed in that way. And so just building up the new practice.
It's I always say happy wife, happy life, right? So if you're you got to make sure your wife's happy. If not, it's going to make you miserable. All the hours you work and all the research you do and all the sideline coverage and everything that we do. And I look at, what you do as a physician or even the orthopedics that we deal with as physicians and the hours they work. And then I look at me as an athlete trainer and, a clinical director, and I'm like, I thought I worked a lot of hours and you guys are grinding it. And it definitely shows your passion for medicine. And I think a lot of us that have gotten into our careers did it for the same reason, right? We want to help people, which is an awesome thing. And I think, like I said earlier, having someone like you with the experience you have and the passion that you have in losing you is a great loss for us in Boston and for our affiliates that we work with. But they're gaining an amazing physician in Philadelphia.
I appreciate that. Boston was a hard place to leave for sure. I had only the best experience at Boston Children's Hospital with Northeastern and UMass Boston and all of my teams that I covered there. Just a tremendous place to practice for a long time. So it was a tough leave for sure. Excited for new opportunities. So we'll see what we can make out of it.
Yeah, it's great. What if there was, what is your passion in the sports medicine realm? I mean, pediatrics is kind of your wheelhouse. What do you like to do the most? Is it more concussion related? Is it more, the overhead athlete? Is it a combination of both? Is it, everything kind of under the umbrella? What is it that you tend to gravitate to the most?
Yeah, I think probably the most maybe publications or speaking that I've done has probably been on concussion and then some spine injury and throwing athlete for sure. I think baseball medicine is a real passion of mine just because I love the sport so much. From a care standpoint, I really take a great deal of pride in sort of being a jack of all trades. That's why I really like doing team medicine, being a team physician at the collegiate level. Because I kind of I always would say, hey, if you're an athlete, I'm your guy, right? Like I'll be the first guy. I may not be the end guy. It might be that you see me and then I get you to the right guy, but I'm happy to be that person. I think in today's very academic world, especially in sports medicine at the professional or college or youth levels, it's easy to get super siloed and get super narrowed into one topic. And I really I enjoy concussion a lot. It's such a developing field. I love baseball medicine, but I kind of like to take care of everything.
Yeah, it's I think that's why I feel like being an athlete trained, that's what I like the most about it, because I'm hitting everything all the time and I'm seeing everything at any given time that walks through the door. And it's almost like you can have a car wreck and you're like, well, you have to then figure it out and then be able to triage it in the right way and then be able to refer it to the right specialist. And that's where you guys came in. And kind of one of the things that I think a lot of, consumers don't understand or athletes don't understand the difference between primary care sports medicine and orthopedic surgery. And every time we see an athlete, they're like, well, do I have to go see the surgeon? No, you don't need to see the surgeon. You don't need surgery. We need to see, a primary care specialist that actually can see you and be able to then assess and then add any type of diagnostic testing that is needed that we need. They can order all that stuff. And just to get them, because the orthopedic, as the surgeons are busy enough as it is. And to be able to, get someone in with a grade 2 ankle sprain to see one of the surgeons sometimes doesn't make sense. So that's where you guys come in.
I think you got to have the team, right? Like I think that anybody in medical sports needs a surgeon. Anybody who's a surgeon needs somebody in medical sports. I think that the way that you balance that out, because in the same way that I'm not going to the operating room, that surgeon's not going to take care of concussions, right? And so there's so much of sports medicine that is non-surgical, and the way that, especially pediatric, adolescent, sports medicine, the way that that's advanced, the way that you look at sports specialization and the pseudo professionalization of sport for youth athletes, it's intense, and so you need high level medicine care. You need a whole team, and so I think the key is getting to the right team, right? Having a team that's got athletic trainers, having a team that has everybody, medical sports medicine, surgeon, dietitian, mental wellness, everything. You got to have it all if you're going to be in a higher level sports medicine field. You got to have the whole team for sure.
Yeah, when I got out of Northeastern, and I'm gonna, show my age here. I graduated in 1996 from Northeastern, and my first job was with Carl Gustafson, as you know well.
Yep.
Carl hired me out of college. I then went to work as an athletic trainer for Emmanuel College, and my first team physician was Dr. Demacourt. So I was exposed to primary care sports medicine out of the gate, not knowing what it was. Got introduced to Dr. McKaylee, and then from there it just snowballed into relationships. From Dr. McKaylee, Dr. Coker, meeting you and the rest of the team as you added into the system. But that's how I was exposed. And I always knew that was the way for me to be able to build those relationships as an athletic trainer, but also knew where I needed to send athletes. And then again, like you said, work in a team atmosphere where we had physical therapy, we had primary care sports med, we had orthopedic surgeons, we had nutritionists, we had sports psychologists. And now you add in the mix, like you said, we have sports science. So you throw sports science in there, which is just blowing up now when it comes to being able to make sure that you're taking care of your athletes the right way, but also understanding their performance levels. So that's how I was exposed. And I think Children's Hospital, and more importantly, Dr. McKaylee and the sports medicine division, I feel we're at the forefront of that. And that's where that kind of took off and blew up. And then the McKaylee Center happened.
Yeah, it's in my time. So I did my sports medicine fellowship in 2011, 2012. And so just in that timeline, the advance in what it means to be in pediatric and adolescent sports medicine has just, it's just exploded. And so it's great that you had that early exposure. I think there's still a little bit of a sense of, what does sports medicine really mean? Because it can mean so many things, right? It can be athletic trainers, it can be physical therapists. And so I think sometimes when I say, people say, what do you do? I say, I'm a sports medicine doctor. Sometimes you see them kind of cock their head and they say, oh, like you do surgery, like you do physical therapy? Like, no, I do, diagnostics, that I do, treat sort of everything under the sun if it comes to sports medicine. So it's still advancing for sure, but I've been really happy to see the way that it's blown up so much.
Yeah, you and I chatted a little bit before we started, our discussion today, and it's good to hear that the athletic trainers that you guys have in the clinic in Philadelphia, and you did have them in Children's in Boston, but it's definitely taking on a new shape, especially for physician extenders in the athletic training world. But when I ever needed something, it was a quick email to Dr. Me and Dr. O'Brien, or even Dr. Hayworth, as he served on the sideline with me at Weston when he was a fellow with Dr. Gill over at MGH. And then when he then went to Children's, he ended up staying at Children's. So being able to recognize the skeletal immature patient and figuring out the best way to transcend that down to the sports medicine staff has always been a great way for us to make the patient feel better and the patient know that they were in the best hands. And, whoever the athletes that I dealt with saw, whether it was you, Dr. O'Brien, Dr. Straccolini, Dr. Gianamani, anybody in that group, we were happy to get them in, and they did a great job no matter what. So we knew that the staff had what we needed as far as experience, but also the athlete would feel comfortable with seeing anybody they saw there.
Yeah, I think you have to, if you're going to be in athletics, if you're going to be in sports medicine, you got to be with a team that knows what they're looking at, knows the sport, knows the language. If you can talk to the athlete and about their sport, whether it's baseball, basketball, dance, gymnastics, some of these more narrow aspects that's a little bit more protected, like gymnastics or certain parts of dance. If you can speak their language, they're going to trust you a lot more. They're going to listen to the recommendations a lot more. But part of that is having the awareness. You look at a baseball athlete down to the elbow, right? If you've got a baseball athlete, if you've got a thrower, a pitcher who's got pain on the inside of his elbow, the 10-year-old injury is different than the 12-year-old injury is different than the 16-year-old injury is different than
Right.
the 18-year-old injury, right? And so like having a sense of where do we go along that pathway is huge. You got to have people who that's what they do every day.
Uh, Tell us a little bit about where you are now. So in Philadelphia, starting kind of fresh. What's the staffing look like for you guys? Like, how do you and your team, who's on your team? Like, if you look at, go into the office and see, okay, primary care, sports med, nutrition, like, what do you have available? So if somebody wants to see you in the clinic and you have to then refer to, what does that look like in comparison to where you were at McKaylee and Children's?
Yeah. So in Philly at Children's Hospital of Philadelphia, orthopedics and sports medicine has a ton of overlap. And so we have sports trained surgeons and then orthopedic surgeons who are not necessarily just sports trained. And then we have a bunch of us who are, most of us pediatric trained and then sports medicine trained. And so if you come see me, I'm working every day with an athletic trainer, maybe a PA. I might have residents or medical students or shadowers with me. And then we've got our on-site radiology, so we've got x-rays as we need to. We refer for advanced imaging, MRI, CT as we need to. And then if ultimately we've got a surgical need, then I've got a tremendous surgical team, and they all have their specialties too, whether it's ACL or benign bone lesions or whatever it is. So we've got a really complete team, and then separately we have a relatively incorporated but almost somewhat separate concussion team. We call it Minds Matter team, and it's got everything. We've got social workers, we've got mental wellness, we've got neuropsychology, we've got within that group, we've got nurse practitioners, we've got athletic trainers, and we've got docs like myself who see concussions on a daily basis. So the team is super multidisciplinary here at Philly, same as we had in Boston. It's set up a little bit differently. Sports medicine was kind of in its own little house at Boston Children's, but we had sort of all those players. In Philly, it's a little bit incorporated into orthopedics more, but the operation's pretty similar in terms of everything's under the same roof.
Athletic trainers that work with you, what is their, because I always like to ask in different regions, because we know how Massachusetts is so, it's, you're kind of held by, obviously, the legislation, the regulation, and the CARE Act. What is the responsibility in Philadelphia for the athletic trainers that work with you in the clinic compared to them working on their own nutritional setting?
Yeah, so it's really it's very different in Philly than what we had in Boston. So in my clinic every day, I've got an athletic trainer, and boy, they're what keeps me rolling. I mean, they can serve as a scribe, so they're doing a lot of documentation. They evaluate imaging with me. They evaluate, so they might. I might go in with them at the same time, and we see the patient together, and they're serving almost mostly as a scribe. There are other times where we, clinic is busy. They'll go see one patient first while I go see another patient. We come back together. We talk about the patient that they saw. We make some decisions about imaging that might be needed. And then we look at that together. We talk about a treatment plan. It's great to get the insight because all of our athletic trainers now work with us full-time in clinic, but they all come from a background of kind of standard athletic training where they've been in sidelines at high schools or colleges or wherever they've been. So it's a great separate sort of view to have of having that recognition of, if you spent time on the sideline managing athletes as part of a big team, it's what it takes to get that person back on the field or have that conversation with the athletic trainer or the coaches, whatever it might be. So having that viewpoint's a big part of our practice every day.
Yeah, I think it's that's awesome because we talk about this quite often, and I sit on the board of Allied Health for the state of Mass, and we talk about this all the time. And I don't know if you know Jamie Musler. Jamie was is an athletic trainer, but he also was the director of the movement lab at Northeastern over at Baracus. He was an athletic trainer for a long time clinically, and then he got out of it. He was the director at Northeastern for athletic training before, all the way up to when they eliminated the program. But Jamie and I have known each other for 25 years or longer, almost 30. And because I was one of his clinical students when I was going through Northeastern, so we've had a long relationship. But we talk about this all the time, and the expertise of an athletic trainer and their sideline skill and their evaluative skill and their rehabilitation skill and their ability to teach and understand the injury right from the get-go is very valuable. But the way some of the states have written their legislation or their practice acts, it is very limiting to what they can do and what they can't do. And there's so many opportunities as physician extenders in the clinical setting, but even if you think about it, in the OR to help, not I mean, obviously not surgical, but a lot of us were trained to be able to do sutures and wound closure, and that's part of the curriculum now, and that's a standard of care. So it's like, how can we help the physicians? It's almost like, would you rather have a surgical tech that had 60 hours of training, or an athletic trainer that had 5 to 6 years of training as an athletic trainer, help you in clinic and do the things that
Yeah.
would be beneficial for the patient?
Yeah, I mean, I think that that exposure through the training that you guys get, and that sort of that comprehensive knowledge of, because really, when you're talking about sports medicine, you're not talking about in the clinic. You're talking about out on the field, right? Like you're talking
Right.
about on the playing surface. So you got to know that, and so we can come up with a great plan. But somebody's got to execute it. And so
Right.
I just saw a kid in clinic this week who's about to be a freshman at a D1 school, and he was talking about this injury, and he said, I haven't really talked to my coaches about it, right? And he said, I talked to somebody. They said not to bring it up because I don't want to lose time.
That's right.
I said, look, man, there's a lot of politics to that, but the one thing you got to do is that the moment that you show up to your school, the first thing you got to do is have a real open conversation with your trainer, right?
Right.
Because that's
Right.
going to be your secret. That's going to be the person that's going to help guide you.
Yeah.
And so I think whether it's in clinic or on the phone or in the or whatever it is, I think that having that knowledge of what it means to execute a care plan and what that means in the real athletic setting of once it's out of the hospital, right? Like
Right.
you can create a great plan, but the moment they leave the clinic, I don't have control anymore. So having that relationship with the community trainers is it's what allows anything that I come up with to actually come to execution.
Yeah, I mean, you mentioned relationships with your athletes, and I look back to the relationships I've actually had with athletes in the high school setting, and that's where I've been, other than the 2 years in the collegiate setting, from all of my career. And the relationships you build are like lifelong, because those athletes, if you did the right thing for them and you looked out for them, they're going to come back and ask you, even when they're in college, or even, they'll ask, oh, can you see one of my parents? Like, they'll refer, and that's the best, I think, relationship to have, and it makes you feel good that you're doing the right thing for them. And you mentioned the Division I athlete that's going to be a freshman. I would have been like, wink, wink, medical red shirt. You get a year of eligibility for grad school.
yeah, no kidding, right?
They're not thinking
Bonus
that
year,
far ahead.
yeah. It's I think. I think again having that knowledge of what it means to execute a care plan is just it doesn't matter. It doesn't matter how good a plan I can create if there's not somebody on the backside that can help that athlete execute it and get back to what we're looking at. So it's super important.
What you mentioned baseball. You're a big baseball guy, I know, because I remember bumping into you at the airport probably about 4 years ago, maybe. Ian McPherson, we were going out to a leadership conference in Boston, and you were going to, I think, out to Nebraska to see a baseball game. What are the baseball injuries you like to treat the most? Like, I always like to ask, like, the specialty questions, like, are you an overhead throwing guy? Do you like to see those cuff injuries? Do you like to see the elbow injuries? What do you feel you can influence, with a young athlete? And the reason I ask is that we see, my nephew is 13 and he's throwing a ton, and they're going by the USA guidelines, but my sister called and said he threw this many pitches. I go, he's throwing too much. Like, he's going to hurt his elbow. So what are you typically seeing when those come in? Are you getting kids that are, starting out younger and not going by the rules? The coaches aren't going by the rules. And how do you circumvent that? What's the conversation you have?
Yeah, that's something we talk about daily, because I think that the bottom line, and I talk about this with families a ton. The bottom line is that the baseball throwing mechanism is a unique one, right? It's different than the football throw. It's different than a basketball shot. It's different, and you know that because any kid who comes in with an elbow injury from pitching, usually can do everything else,
Right.
mostly pain free, right? Like they're fine if they do anything else, and it's the baseball throw that gets them. So that 5 ounce weight sitting in their palm as they go through it, a regular pitch mechanism in particular, you can see it in all throwers, but pitchers are the ones that we see the most. It's just a stressful mechanism, and
Yeah.
you're doing that at high volumes. And so the evil is the volume, right? The numbers are the problem.
Mm-hmm.
And so sometimes the pitch safe guidelines or whatever numbers people are going by, that's fine if it works, but not
Mm-hmm.
if it doesn't, right?
Mm-hmm.
And so if you're throwing all by the numbers, which you're probably not, because you're probably not counting your, if a pitcher goes out and he pitches 5 innings and you count his pitches, well, are you counting all the pitches every time he steps out on the mound and gets his warm-up pitches before
Correct.
the batter steps up?
Yeah.
All
Yeah.
the warm-up pitches beforehand, the days before, right? And so it's really easy to lose those numbers. And again, a lot of kids get away with it. A lot of them don't, and that's who I see. And so that perspective is different because I'm seeing all the ones that are having the trouble. And it's frustrating, I think, for families because most of the kids you come in and you say, look, you're throwing too much, right? And maybe it's just because their numbers are too high. Maybe it's because they're playing on 3 different teams. I saw a kid this week which had the absolute sort of no, which is he's the pitcher and a catcher. And you just say, like, you can't do it. You can't pitch every pitch and then throw back every pitch. And so you look at these combos, a lot of it I think is too many teams, and now it's all about tournament play, and the scope of baseball has changed. And so ultimately I like seeing all of these injuries. When I was at Boston Children's, we set up a great throwers program where we did some slow motion analysis, and I loved going through those things. And my version of pitching mechanic analysis is different than if you're seeing a pitching coach, because the pitching coach is going for velocity and I'm going for protection.
Right.
But I don't think those things fight each other. That's what I would always tell families is that what you want is speed and what I want is efficiency, right? Like what I want is for you to not alter your velocity just through your arm.
Right.
And so I don't think I fight velocity. I think I have potential to create velocity if I can, probably 80% of the kids who I saw running through slow motion analysis, the problem was they got a cannon of the arm and not using anything else. They're not using their hips. They're not using their lower body. And so if we could get those, if I say, hey, if you're fast with just your arm, imagine what you could be if you use your whole body, right?
Right.
And then if we could keep you training because you're not getting injuries. And so I think going through those analyses and looking at their numbers and thinking about what's smart for us as baseball players in the youth. I love baseball. I think it's the best sport. I was a baseball coach. I was a baseball umpire, and now I do baseball medicine. But there's so many changes in the scope of baseball, and trying to take these kids that are, I give a bunch of lectures on throwing medicine, and I open up with this thing that I saw on Twitter that was like, names to know for 9U nationally.
Yeah.
And it's just like, what are we doing? Why is there a 9-year-old who I'm supposed to know who they are? What are we doing?
Exactly.
So that
by 11, he's not going to have an elbow.
Right. Exactly. Yeah. Mom asked me that the other day. She said, "What we want him." Yeah, I think the kid was 10 or 11 years old. She said, "We want him to do really well. Maybe up to the college because he's we're being told that he's really good." And I said, well, then stop what you're doing. You got to stop what you're doing. Right. Like this kid. Yeah.
Let him be a kid. Let him grow up,
and play different positions. And play different sports. It's
it's interesting because I always loved the shoulder. I still do. And I feel like I love talking to pitchers, and even also I deal with a lot of swimmers. Weston has an unbelievable swimming program. We were like, won 2 or 3 national championships and dual meets. We've been state champs, I think, 18 times since I've been there. I mean, they're unbelievable. They turn a lot of kids to Division I. So I get to see a lot of the shoulder stuff that you end up seeing in clinic too. My fascination with it is the same thing. When I see an elbow injury, usually it's because their cuff is not strong enough, right? They're not working what they need to work. They're not using their hips. They're not using their trunk. They're not using their core. So I like to break them down and look at their mechanics. And obviously don't have a slow motion, analysis like you guys did at Children's, but I could send them over there if needed. But I do try to do the best analysis I can in clinic and be able to fine tune what they need to do and get them on a good program and get them on the throwers 10 and work with them. to be able to keep them injury free and make sure we're doing the right thing. But once they start to understand that you don't need to do cleans, deadlifts, bench press, like we can start with red band tubing, work essential muscle groups, get the stabilization where it needs to be, start working light dumbbells, and then make sure they do that stuff throughout their workouts while they're still training, then they'll actually be pretty successful. It's once they get out of they start going to a lot of these sports performance places now and they're throwing stuff around like it's, they want to be power lifters. And for me, I
Yeah.
feel like they definitely overtrain, and that's where we start to see problems. That that being said, once we educate them in the right way, then there's like an aha moment for them. I had two baseball pitchers in the last 2 seasons that we had gone through with, and as soon as we put them on that program, it was didn't see them the rest of the season. They were,
Yeah.
did great. So I think if we can identify those things, it's rewarding for us because we're doing the right thing. Now, as far as sports performance, you guys had a pretty good program over at McKaylee where you guys had the athletic trainers doing it. And I think Sean was doing some stuff there with kind of sports specific stuff. What do you guys have available over where you are now in Philly? Is there anything that's, related to that,
Yeah.
simply, sport performance or more like analysis type stuff?
So not yet. My goal is that hopefully one of the goals of me coming here is that we can build some of those things similarly. We have a tremendous physical therapy program, and so we have a great sports PT. We just started an accredited sports PT fellowship at CHOP, so that the physical therapy team at CHOP is amazing. But in terms of almost like a preventative thing, we don't have it as much now.
Yeah.
I sort of do that a lot, right? So again, if I see a kid who's got little league elbow, if he's got growth plate stress from throwing, I always get those kids in PT. The truth is, there's not a whole lot you can do about the elbow, right? They can
Right.
work on flexor extensors, but I don't really care about the elbow.
It's the shoulder.
The treatment of the elbow is stop throwing,
Yeah.
and then we go, how do we prevent this from for next time?
Right.
And so then it's just you chase it up, right? You chase up the shoulder, and most of the time it's controlling the scapula, right? Like what's the stability of the shoulder?
Right.
You say you love the shoulder. I have a love hate with the shoulder, right? Like it's a complex joint. I think the shoulder is similar to the low back. I tell families all the time, if you got one shoulder problem, you got 10 shoulder problems, and I'm probably seeing the 10th, and I got to crawl back to the first. And so I think it's a complex joint that's hard to treat, but I think that if you take something like an elbow injury so often, you're right. And similar to swimmers, right? Swimmers, I tell all my swimmers, you're just a baseball pitcher. You just happen to throw from both sides.
Right. Exactly.
Yeah. And so I think if you can chase it back and work on, periscapular and postural aspects and getting those shoulders nice and stable and getting the motion there. And so we sort of use that almost, I suppose, treatment as prevention. But hopefully we continue to advance a more preventative or performance aspect.
Yeah, you can see my Yaz 67 Hall of Fame picture there from the World Series.
Yeah.
Yeah, I'm a big baseball guy. I like it. I, again, love-hate relationship with it. I tell patients that come in, even older patients, when they come in with cuff repairs, I said, you got to think of your shoulder as the four tires on your car. If you lose one of the weights on the wheel, then your car's off balance. It's like you have to get in a car alignment. So think of that when you have a cuff repair, you're losing 1, 2, or 3, right? Hopefully not everything. But that's what we have to do is add the weight back on the wheel so it stays balanced and controlled. And that's what I try to tell the young athletes. And I think, for them to understand that, I think it gives them a little bit more hope of, okay, yeah, I can get better from this and I'll be fine.
Yeah. Yeah. I think we've got a really tremendous team at CHOP. And I think the growth of sports medicine at Children's Hospital of Philadelphia has been really great. They're really smart about the way that they're building this, and so I think we'll only continue to go in that direction.
Yeah, I mean, I think that's kind of the future, right? They want everything under one roof, right? I think that's the big thing, and that's where I think the visionary of the vision of Dr. McKaylee was like with everything. I look back at when he started. Talking to Carl about how he started way back, early in the sports medicine phase of being like the sports medicine physician, right? Or the sports medicine orthopedic. And then they started identifying, stress fractures in the lower back. Like they were the ones that started like identifying that, right? So I think, continuing to do that stuff and move forward. I mean, you have to keep innovating and revolutionizing the profession in order to stay ahead of it. But also, people are going to keep looking for that specialty, but they want everything under one roof.
Yeah, and I think we're getting really good at identifying injury through, an awareness of injury patterns and sport-specific injury patterns. And I think we're really good at identifying injury. I think we're getting a lot better about treating sports injuries. But again, you see those same patterns, and that was always that's where the idea of the McKaylee Center for Injury Prevention came out. Was we see the same patterns again and again and again. At some point, you go, what are we doing here? Why? How do we prevent this? How do we get in the front of this? Because we just, when you see 100 kids with the same diagnosis, and you can smell it as soon as you walk in the door, what that diagnosis is. You say, hey, we got to be able to get in front of it.
Can you speak a little bit about, what you're doing now or seeing now as far as concussion? So what I mean by that is kind of talking to the consumer about concussion. We've had this big thing for 15, 20 years now with concussion. The revolutionizing of the evaluation tools and the sideline assessment tools and the neurocognitive testing. And even the athletes now are very good about reporting and, making sure that they're getting the right treatment. What's kind of the standard of care, just to let the people know that might be listening, for a child that comes in that might have been diagnosed with a head injury, and kind of how do you guys deal with that moving forward?
Yeah, so here at Children's Hospital of Philadelphia, we have a pretty comprehensive program. Essentially, you should be seeing somebody who sees concussion, right? Like that they are a concussion specialist, that they have been had advanced training in it, because it changes. I mean, it's in the shy of 15 years that I've been doing sports medicine, how we treat concussion has changed fairly significantly just in that timeline. And
Correct.
So if you think about medicine, having that level of change in a 10 to 15 year period is huge, and it continues to change, right? And so we've really swung. We initially did way too little for concussion. It's like, you hold how many fingers am I holding up, and you get back in. And then if anything,
Right.
maybe we swung too far of like putting kids in a dark room and wait until they get better. But of course, you take an adolescent whose whole, their identity is my academics, my social circle, and my social circle includes electronics, and then my sports. And then we sit you in a dark room and we say, hey, let me know when you're feeling back to normal. Well, that answer is never. I don't feel normal at all. I'm terribly stressed about my academics because you won't let me do anything. I haven't seen my friends. I can't go to sports. I can't do anything. And so now we've swung back a little bit in a protective but aggressive way about getting people back to safe activity. And I think in the last 10 years, probably the greatest advance that I've seen is this real awareness that, hey, after those first 24, 48 hours, if kids are feeling better, we got to push them back into safe activity. Still not a risk of contact or collision. You're still not getting cleared until you're symptom free and back to normal. But getting them back into safe activity is just so crucial, so that we don't see the fallout, right? Like we don't see the fallout of them having bigger adjustment reactions and stress and anxiety surrounding. I can't be around my friends. I can't do these activities. It just magnifies the symptoms. And so, and then from an identification standpoint, we've had some great advancements in terms of identification, and we're trying so hard. But the truth is we're trying really hard to get an objective assessment of a really subjective, blurry thing.
Correct.
And so concussion is this sort of different beast. One of the things I love about sports medicine and why I chose it is that it's very tangible, right? Like you get a hands-on exam and you can feel the joint, you get imaging, you can see these things that are fairly concrete. And then concussion is the opposite of that.
Correct.
Right? It is subjective, and how do you feel, and try this, and then how do you respond to that? And so it's so difficult to have a really great proof of anything. And then as hard as it is to prove if you got a concussion, that's probably the easy part. It's how do you prove when I'm back? How do you prove when I'm relatively safe to return, and what's my risk versus others? I think that's the most difficult part. So I think you just need to be, I think if you're a parent and you've got a kid in sports, or a kid who's active, right? Like we see a lot of pediatric concussions that probably the number one cause of concussion if you're 11 or below is recreational play. And so we can
Right.
talk about the soccer team or the football team or whatever else they got going on. But if they're out at recess or they're playing basketball with their friends, they're just as likely, if not more likely, to have those injuries. So I think knowing who your team is, right? Like in whatever city, whatever town you're at, you should have a team and you say, hey, here's who does pediatric concussion. And so you're getting that, best assessment and then the best advice and the best guidance in getting back into school and the best guidance about getting back into exercise and eventually sport. And then what does that mean?
Mm-hmm.
Right? Having an open discussion, because there's a lot we don't know, right? Like the truth
Right.
is that we see a lot of great advances in concussion. We still see a lot of bad news about concussion. There's some real murky waters of the connection to down the stream effects or long term effects that we're still not wrapping our brains around, no pun intended, entirely, that we don't have the best knowledge of that. And so I think having somebody who can have a real open discussion about what risks are as they move forward, I think you just got to have somebody who that's what they do every day.
Yeah, that's I 100% agree, because I've been very fortunate in being exposed to concussion, obviously working with high school athletes in football and for my whole career. We started using neurocognitive testing right at the infancy. We had the ability to be able to have it as a tool. And I always say it's a tool. It's not
Mm-hmm.
a complete diagnostic, return to play criteria, cut and dry. Everything that we do is diagnostic in a way to be able to provide the best environment for the athlete to progress them. So I feel like we at Weston and the people I've been surrounded by, Dr. Meehan, Dr. O'Brien, Dr. Neil McGrath, I've worked with, with Mickey Collins, working with him, speaking to the people, going to the conferences and learning more about the injury. Again, like you said, it's the injury it's the unseen injury. You can't put your hands on it, right? So I feel you need to know your athlete. You need to know who you're dealing with. You need to know them physically, but also mentally and what they deal with, because we started to see this, years ago. I remember talking to Mickey Collins about this, is that, if we withhold people out of activity because we're waiting for them to be completely symptom free, you're going to start to see these myriad of symptoms that cross over to psychosocial, psychosomatic, anxiety, depression, all this other stuff that's going to fall into place. And the kids then academically are stressed and strained, because the community that we're in, if they miss 2 or 3 days of school, it's like 3 or 4 weeks for somebody. So for them, they're so overloaded that we try to do as much as we can to try to prevent that from happening and provide a good team-based approach. So we're working academically with them, we're working physically with them. Like you said, symptoms start to reside, a little bit on their checklist. We're getting subjective data from them. We're going to start you exercising on a stationary bike. We're going to start you moving and being part of your team, just being there and listening and standing there and watching and doing something that's going to help them feel better. Then they see that light. It's almost that light at the end of the tunnel for them, and they feel better. And if you know the athlete, you can make the right clinical decision. And we use the tools that we use, VOMs, for our sideline assessment. We'll do our neurocognitive testing using Sway Medical now. Things that I can then take and use and say, hey, listen, this is what we're going to look at. But you know what? This score might be a little off because I tested you at the end of the day. You had an 8-hour academic day. Of course, you're not going to test well. So let's test you in the morning. So things that we can do subjectively, objectively, and then be able to make sure that we're doing the right thing for the athlete. But like you said, having a medical team that understands how to progress somebody and put them back safely in a manner that doesn't just look at testing. It's like, hey, what about the athlete? What are they feeling? What are they doing? And how the parents responding to how they are at home.
Yeah, I mean, again, like we can use Sway. We use it again. We're trying so desperately to use these tools to try and create a score, right? Like to
Right.
create some concrete thing, and it doesn't work
Not with
as
everybody,
much as
right?
we want it to, right? And so then what else do you use? You use symptoms,
Right.
and so we use our symptom scores. But again, like every single symptom that's on that post-concussion symptom scale, every symptom you can have just from life, right? And
Yeah.
so that if you
You have
take an active
cervicogenic
kid,
pain, and then you have half of those symptoms.
yeah, or even what do we do? So then you take, let's take, whether it's a 10-year-old or one of the Patriots. If you take somebody who's used to having a ton of activity, and you
Mm-hmm.
say, "Hey, you had this concussion. You can't go out." I was exercising 6 days a week, 7 days a week, and now I'm sitting at home waiting for somebody to tell me that I'm better. Their appetite goes down, their mood goes down, they feel tired, they feel fatigued, they have poor sleep function, right?
Right.
So then they get sleep disturbance, and then they feel now actually now I feel like I'm more anxious through my day. Now I feel like I'm having more distraction during school. I think my memory's suffering, right? And their memory's not suffering. They're not focused because they don't have the exercise that's completing their day. Their energy levels are different. Their sleep levels are different. So everything changes, right? And so then you're trying to throw darts in a moving target, right? So again, like the more that you can, I always talk about you got to normalize your life, right? As much as we can in a safe way, you got to normalize your life. Because if you say, hey, I feel like $1,000,000, but all I'm doing is sitting on the couch all day, that doesn't tell me anything. If you say, I feel terrible, but I'm pushing myself through all these symptoms, that doesn't tell me anything. We got to progress you back through everything. And then if you say, hey, I feel normal and I've done everything but get hit, right? Like I always tell families, that's what I'm looking for. I've high level exercise, high level cognitive activity. I'm back to school. I'm back with my friends. I'm back doing too much screen time. I'm playing too many video games. I'm doing all those things. Great. That's what I need to know. Because then if you tell me you're normal, then I can believe it.
Yeah. I mean, the sports scientist in me, I'm always looking for other ways to kind of monitor. And the biggest thing that I can tell you happens all the time. They're up too late. They're on their phones too much, and they don't sleep. They don't eat well. They're not hydrating. They're not doing the things we ask them to do, which will make them feel better off the bat. Is there anything on the forefront? Have you seen anything on just sleep pattern assessment or sleep pattern research that we could actually, that's easy enough for us to do. We could put them in an Oura ring. We could put them in a Whoop. We can do anything to be able to monitor that, because we know, I was talking to Dr. Mean about this. We wanted to do a sleep study looking at performance-based, but then injury reduction. Where are we seeing it if they have good sleep? I mean, concussion, that's almost like a home run.
Yeah, I haven't seen, we know that sleep disturbance is a symptom of concussion, right, from the pathophysiology of concussion. We also know that it can result from all the adjustments that we make because of concussion. Again, you take them out of exercise, and so it messes up their sleep patterns. And so I haven't seen great literature that says, hey, this proves it, but we've got all the connections there, right? Like at the collegiate level, especially in the last 5 years, just amazing amount of literature that shows the significance of sleep and its association with musculoskeletal injury and mood disorders in collegiate athletes, right? Like there's great literature there. We know that concussion injuries actually then subsequently can increase your risk of musculoskeletal injuries, whether that's coordination or deconditioning or whatever it is. And so there's, those connections are there, but we've just sort of like got scattered dots that we got to connect. But I think you're right. I think that's a ripe area for continued research. Is again, now we have the monitors, right? Like you strap a Whoop on a bunch of these kids and watch their sleep. The key would be what's their baseline versus what's their post-concussive sleep. I think having that's the hard part, because if you get a kid who's concussed and you track their sleep patterns and you say, oh, well, see, this is the problem, they're getting such poor sleep, but you don't know what their sleep hygiene was.
We need to get them beforehand.
Yeah. You got to get them, preseason, everybody gets a Whoop. Let's monitor you through the season, look at the difference between the kids who get concussed and who don't afterwards, right? To see
right. Maybe that's a discussion for you, myself, and Dr. Meehan to have, because I'm trying to push to do something with sleep, and I just need the platform to do it, because I did my thesis on sleep and injury reduction and sleep and injury improvement, and the literature that I was able to find showed that, and really the only literature that I didn't find any in adolescents. It was more collegiate, students. They saw a reduction with sleep pattern change. I mean, that was apparent. And we know that with somebody with a cuff injury or cuff repair, if they don't get sleep, their recovery is horrible. If they get sleep, their recovery is good, or better, I should say. So we know that with injury, and we can make that connection. But, thinking about concussion, like you said, how do we get a baseline from them? If we can maybe even Likert scale them through the season until someone has an injury, then throw a Whoop on them. At least you might have something with data, but it's still not going to show us the data that we're looking for, black and white like they would on the Whoop. So it'd be worth trying to look at.
Hey, Whoop's hometown, right? Like
That's right.
Whoop's the local company. Should be able to get those guys.
I know. So maybe a discussion for another day.
Yeah, for sure. Yeah.
What is, one thing that you are looking on the forefront? Like, I think, what's kind of in the future for you as far as research? What are some of the things you want to look at and do moving forward? I know, like you said, you're a big concussion guy, but is there anything else that you're looking at that you want to kind of, expand on and try to and prove a question? or get an answer
Yeah,
for
I
a
think
question.
I guess this is you talk about, you look at the elbow, you go back to the shoulder, and this idea of like, hey, once you find a problem, you got to track it to its roots.
Right.
And so one of the issues with sports medicine, and you're saying like, hey, you got to find the right person, right? You got to
Right.
find the right guy. You got to find the right sports medicine involved person. One of my other passions outside of sports medicine, but directly related to it, is medical education. And so I think for me, one of my big things moving forward is how can we improve our general pediatricians' MSK knowledge, right? Like our musculoskeletal knowledge. As somebody who went through a pediatric residency and was a chief resident and does a ton of teaching, I know that it's not there. It's just not a priority.
Right.
And there's too many things under the sun, right? Like there's just too much to learn when you're true primary care. If you're just doing general pediatrics, those people are saints, right? Like their ability to take care of us on a constant basis is incredible. But I do think that there's great literature that says that pediatricians don't feel confident about their musculoskeletal skills, that they don't get enough training about it. But it's something that hits them, right? Like 30% of all pediatric visits that are not for well child care are for musculoskeletal problems, similar numbers in the ER. And so the data is there that we need it. And so it's a big research push of mine is how can we improve it? How do we improve education innovation?
Yeah, it's interesting because we see it in the PT clinic. We'll see primary care physicians refer to PT, and we're like, why are they at PT? Like, we get it. We'll evaluate them. But it's like you said, it's the knowledge base, the musculoskeletal. My big thing is the concussion of understanding, because we do get some doctors that will write still 1 week out of activity and can resume activity when you feel symptom free.
Yeah.
And I feel like I just want to go to that office and say, what are you guys doing? Like, let's have a conversation and educate more. And again, like you said, they're seeing everything. So what are they focusing their energy towards,
And that's why I think that especially you look at concussion, and if you've got somebody who's been doing pediatrics for 20 years,
right?
What a concussion means has changed
10 times.
10 times, right? Like in their career, it's changed 10 times what it means. And I'm supposed to call it grade 1, 2, 3. Oh no, I'm supposed to call it simple versus complex. Oh, I'm not supposed to call it anything at all. I'm just supposed
you have a head
to
injury,
concussion, right? Like I'm supposed to cocoon them and put them in a dark room. No, I'm supposed to exercise them at 24 to 48
give them sunglasses
hours.
and a hat.
Right. Like it's a moving target. And so I empathize with all of my primary care colleagues that. We're a moving target. And so that's, I think that, when I was at Boston Children's, we actually, it took us a long time, but we created what's called a clinical pathway. Boston Children's has a bunch of them, but we created a clinical pathway, essentially an algorithm of care for primary care to say, hey, a kid comes in with a concussion. What's my assessment? What's my diagnostics? What's my treatment patterns? How do I know when they need to be seen by somebody in the concussion clinic? How do I know when I can send it back? So I think that those are the kind of things, creating these clinical pathways so you standardize care a little bit. And then you can take the expertise of somebody who's doing it every day and filter that in a really packageable, learnable way that can then be updated, right? And so that if they know, if the primary care docs who work through Boston Children's know, hey, I can go to the clinical pathway, and if things have changed, then they're going to change the pathway. That's otherwise you can't keep up with everything. Everything's too advanced.
Right. What's the one fun fact about Dr. Beasley that we want people to know outside of the professional physician?
Yeah, so I guess it's not fun at all. My biggest weakness, my profession is sports, but my biggest weakness is sports. So you saw me on the way to Nebraska. Nebraska's home for me. That's where my family's from. My mom still lives in Nebraska, and so Nebraska sports has always been a huge passion for me. And when I was in high school, that was amazing because we were winning football national championships.
You were.
Right. We were a great team. Yeah. But that was a heck of a long time ago. The last 25 years have been pretty miserable. And so then what do? I marry a girl from Philly, and she brings me into Philly sports. And so here I am. Right. I was banging my head against the wall last night watching the Phillies, who have the best record in baseball, and they are in an absolute free fall. So I guess the not too fun fact is that I was nice and settled in my misery of Nebraska sports, and then I got thrown into the misery of being a Philly sports fan.
That's right. That's pretty good. Hey, but you got cheesesteaks.
And we got cheesesteaks. Yeah, I mean, how do you fight that? Yeah,
You can't really.
yeah,
Our Boston Red Sox aren't doing as bad as everybody thought they were going to do. So we'll see if
so
they can make the stretch here towards the
yeah,
end.
they're
Um,
they're a 500 ball club doing 500 ball club stuff.
yeah,
Yeah,
yeah, we'll see how it goes. We're spoiled up here. You know it. I mean, we've had
yep,
so many championships. I can't complain when a team doesn't do well for several years. It is what it is. I mean, there's
yeah,
so many other
yeah.
teams that are suffering and community suffering for other stuff. So,
Somehow I dodged the Celtics success
yeah,
because I moved. I moved right before they went and finally got themselves another banner.
right, right. Pretty amazing stuff. Well, listen, Dr. Beasley, I appreciate your time. This was a great conversation. I like some of the stuff we talked about. I hope the audience thinks the same, and I wish you the best of luck in the new endeavor over in Philly. And hopefully we can keep these conversations going, and keep in touch. Maybe some research projects on the horizon.
That'd be excellent. Always a pleasure to catch up with you. Even better if we could get some more work together.
Awesome. Thanks, man.
Yeah, thanks a lot.
Thank you for tuning in to the Behind the Sports Medicine podcast, proudly sponsored by AJR Sports Science and Healthcare Consulting. At AJR, we are committed to offering a comprehensive range of exceptional services, including applied sports science analytics, healthcare and sports medicine consulting, and leadership and coaching development. To learn more about AJR, visit their website at ajrsportscience.com. This is your host, Andrew Rizza. If you enjoyed today's episode, give us a like, comment, and share it on social media. Access all of our episodes on platforms such as Apple, Spotify, or your preferred podcast app. Stay updated by following us on Instagram at Behind Sports Med Podcast, on X at AJR Sports Sci, or visiting our website at ajrsportscience.podbean.com. Don't forget to subscribe to our YouTube channel at AJR Sports Science for upcoming content. Thank you for tuning in, and stay tuned for our next episode.